Hello students, and welcome to part 3 of video presentation for module 2 in Nursing 150. For this module we're going to talk about HIV, just kind of go through pathophysiology of it, what puts a patient at risk, what disease processes it causes, and the medications used to treat it. HIV is a blood-borne retrovirus. It was first identified in 1981. In 1981, it's kind of interesting if you look at the history of HIV, how it's progressed and how we've learned so much more about it. In 1981, it was also known as GRID. GRID stood for gay-related immune deficiency. It was thought to be a disease of the homosexual gay men. So now it's known as a serious worldwide epidemic. And we know that it's not just homosexual men that are obtaining it, and we've learned a lot about what this process is. So it's interesting if you talk about people that were in healthcare in 1981, how before HIV was identified, we didn't wear gloves, we didn't have universal precautions. It was truly HIV and the identification of it that skyrocketed us into using universal precautions. So it's an interesting fact about HIV. This is just a slide that talks about now the HIV infections, how it is kind of the population, how much of the population has. It's just a breakdown of races of who has HIV infection in the United States currently. So let's look at the pathophysiology of the HIV virus. To do that and to understand that, we first need to take a look at the CD4 cell. CD4 cell is a type of white blood cell, specifically a lymphocyte, a T lymphocyte that we have in our body, known as the T cells, or the natural killer cells. They are very important in building immunity in our body and to have the ability to fight off disease in our body. Specifically, the CD4 cell. The CD4 cell is a T cell. It's a type of T cell. The 4 represents the number of proteins that it has on it. That's all that comes from the CD4 T cell. And it is also known as the helper/inducer cell. What this means is that its job is to secrete something called lymphokines that actually enhance the ability of the rest of the white blood cells. It increases immune function by doing that. They're sort of the leader. I don't know if we should really call them. They call them helper cells, but I really feel like they're more of the leader. They organize it. They organize the white blood cells to do what they need to be doing to help destroy any kind of antigens in the body. So in summary of all that, basically the CD4 cell is a very important cell in the body that we need. And if the HIV virus is attacking this cell, then our immune system will be compromised. I really, really like this picture. This comes straight from your book. This is on page 359 in your Med-Surg book. I really think that it's a very helpful view on how HIV attacks the cell, and it also explains the medications that we use to treat HIV. So HIV has 2 special features. It has something called, there are 2 enzymes. One is called the reverse transcriptase enzyme, and the other one is integrase. So once the HIV virus attaches to a CD4 T cell, it actually has the ability to make its way into the DNA of the cell and replicate itself. The reverse transcriptase gives the HIV virus the ability to take its RNA and make it into a DNA that is very much like the host. And then the enzyme integrase helps it convert its RNA to more like the host and complete the infection of the CD4 cell. So these 2 enzymes is what really helps the HIV virus take over the cell and replicate itself. There's one other enzyme involved. It's called protease. It is involved, it's a protein that allows it to helps allow the HIV virus to replicate. So when you take a look at the name of the medications that are utilized to treat HIV, they are inhibitors. You'll see integrase inhibitor, a protease inhibitor. Basically what they're doing is trying to inhibit this enzyme from being able to do its thing. So if we can do that, then we can stop the invasion of the HIV virus and stop its ability to replicate itself and infect other cells. This picture also helps you understand why a patient will be given multiple drugs. Patients that are on antiviral therapy with HIV are given multiple drugs. They used to call them cocktails of drugs. And the reason we do that is because we're trying to stop, they'll have a protease inhibitor, they might have an integrase inhibitor, or the reverse transcriptase inhibitor. They might have all three. They might be on all three of them because we're trying to stop all three mechanisms of HIV in order to keep the virus the ability to overcome the cells. So I just want to talk a little bit about the difference between HIV and AIDS. Not everybody with HIV has AIDS. AIDS is the more ill of your patients with HIV. And then the CDC, the Center for Disease Control, has put forth guidelines for when someone actually has been deemed with AIDS instead of just having HIV. So the CDC says that when a patient is deemed to have AIDS is when they have a low CD4 T cell count of less than 200. And then they also have an opportunistic infection. If they have two of those, if they have a low CD4 T cell count less than 200 and an opportunistic infection, then they have AIDS. Normal CD4 T cell count is 800 to 1,000. So you can see if they had less than 200, that would make them very open to infection because they have a low ability to fight off the infection. Let's talk about opportunistic infections. Basically, they are organisms that are present on a normal person's body or in the environment, and they are typically fought off easily by our normal immune system. Patients who have a low CD4 T cell count do not have that ability, so they get these opportunistic infections. They're very rare infections that you don't typically see. And actually, in 1981, that's how they sort of identified this HIV, because people were getting these really weird infections that they hadn't seen in a long time. Kaposi sarcoma, they were seeing that, which was not typically found in young men. Certain types of pneumonia began showing up in patients, the types of pneumonia they hadn't seen in a while. Histoplasmosis, lots of different, and pneumonias were a big one of it. They were seeing very rare pneumonias. If you look in your book on page 360, there's a table 21.1, Center for Disease Control and Prevention Classification of AIDS Defining Condition in Adults. It has a list of some of those opportunistic infections. One of them is pneumocystitis. I can't even say it. Girofichy pneumonia. It's a very rare pneumonia. Recurrent pneumonia. 2 instances within 12 months is listed in there. So just take a look at those and just kind of review those. Those are some of the Kaposi sarcomas listed there as well. These are the different stages of HIV classification. And basically, they're staged as to their CD4 count and any opportunistic infections. So if you're ever working with a patient with HIV and they'll stage it, so you just realize that typically stage 4, their CD4 T cell level count is still with, it's low, but it's, above, it's around 500. It just sort of, basically that's what it is referring to. So education for HIV is the best way to prevent it, and it's a big part of a nurse's role in teaching adults on how it's transmitted and how to prevent it. Basically three ways that it can be transferred, and that's sexual, parenteral, and perinatal. Parenteral is talking about through the bloodstream. So I think we've done a pretty good job in the United States. It's taken us a long time, but we're doing some pretty good progress on educating the country on how to prevent this, how it's spread, and how to prevent it. The interesting thing is that women are the fastest growing group with HIV infection. So we need to make sure that we're educating young women that they can get it and that they need to protect themselves always, 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 always. Just some recommendation from the CDC on how to educate adults on prevention of HIV for sexual transmission. They always, always will promote abstinence first, and then the use of condoms for sure, and then just monogamous relationships. So, it's really important that younger people know how this can be transmitted and that it can happen to them. It absolutely can. And they need to know that it, you can't judge a book by its cover for sure. So they always need to protect themselves. In the workplace, there's a lot of things that have occurred since 1981 to protect healthcare workers. If you look in the American Nurses Association, the president of the American Nurses Association's name is Karen Johnson, and she was stuck by a needle when she was working in a busy ER, and she went to Congress and put into place multiple mandatory mechanisms to protect us, and always, always, always use standard precaution measures for all patients. Always. Again, you cannot judge a book by its cover. Don't think that they don't look like they have anything, because as we'll find out how this disease progresses, patients don't always show signs and symptoms of it when they're a carrier of it. So we always need to use all of our universal precautions, always, always. So basically, when we talk about the assessment of a patient, when a patient comes in and you're trying to establish what they're at risk for, it's always talking about what type of occupation they have, their social history for sure. Are they doing any kind of recreational drugs where they might be sharing needles with someone? When you talk about maybe their social history, are they sexually active? Do they have more than one partner? Those kind of things are questions that we're asking, and that is to establish whether they are at risk for maybe having HIV, because patients don't automatically show the symptoms and they can be a carrier of the virus. So a patient can be infected with the virus and not show any signs and symptoms of it. If they have been infected and they are a carrier of it, they could actually be spreading it without even knowing it. So it's really important to do screening as we see each patient on whether they're at risk for it. And if they are at risk, if they're established to be at risk, we need to make sure that we do testing to determine whether they have it or not. And we'll talk a little bit about the tests that can be done if somebody has been looked at as being at risk for having it. And then on the flip side of that, if we have a patient that hasn't been diagnosed with HIV, but they're coming in with clinical manifestations of it, especially those opportunistic diseases that I talked about, if they're coming in with Kaposi sarcoma, some of these rare pneumonias, then maybe they need to be HIV tested to see if that's why they have these opportunistic infections. These are just other clinical manifestations that happen with AIDS. You can just kind of look through those in your book, but these typically do not happen until someone has been deemed of having AIDS. They're typically your sicker patient, the dementia. That's kind of a new phenomenon that they've started getting more research on, is that it does make them have a type of dementia as they get in the later stages of HIV and AIDS. So talking about labs to test a patient for HIV. Viral load. Viral load should essentially be nothing in a patient. Basically, it's the amount of virus present in a patient present in their blood. The normal patient should not have any viral load. If it is high, that means there's a large amount of the virus present in their body. The higher their levels of the viral load, the greater risk they are for transmitting it. They also use this lab value to determine how well the medications are working for a patient. So if patient's viral load is very low, that means that the medication is working well for them. So they sort of use it throughout their treatment for HIV with the medications to make sure that the medication is working for them. So they would expect those loads to be low. Laboratory tests to test a patient for HIV. Of course, your lymphocyte counts. If your lymphocyte counts are low, that would be indicative of HIV. Now, it's not positively. It's just something that would go along with other signs and symptoms if their lymphocyte counts were low. Other things can lower your lymphocyte count, but it could be something that just kind of is an indicator of HIV. And of course your CD4 T cell counts. If those are low, then that's going to trigger somebody, a physician or a caregiver, to think, why is their CD4 T cells low? Antibody test. So when you think about the immune system, you know that we build up antibodies to fight off foreign antigens that attack our body. So if a virus is coming in and attacking our body, we should build up an antibody against that. The ELISA and the Western blot are tests that can test for antibodies. The interesting thing about the antibodies that we build up for HIV, though, is we don't typically start making the antibodies for 3 to 3 months after the infection first occurs. And then some people, the antibodies are not made for a very long time. It can be up to a year after they are infected with the virus. So these antibody tests are not going to show up right away. They're not going to be an indicator right away. So if most people, if they feel like they've been exposed to the virus or they feel they're at risk, they will do they'll do them at different times afterwards to make sure that they are not building up these antibodies, because you won't build them up right away. The ELISA is your initial test that will be done. It's an inexpensive test for HIV. However, it can be negative, falsely negative sometimes, because if we do it before the antibodies have built up, it can be deceiving. This test can also have false positive results. So here's how this works. The ELISA is done first. If we're testing someone that we fear may have HIV, we will test them with the ELISA. If it is positive, then we will perform the Western blot test. The Western blot is done after the ELISA because it's much more expensive. It is more sophisticated. It's a little bit more accurate. So this is how this happens. If they do the ELISA and they're positive, then they'll have the patient come in and have the Western blot test done. And these are both blood tests. Once the Western blot is positive, it is then and only then will they say that a patient has HIV. The ELISA and the Western blot test both have to be positive in order for them to tell the patient that they do have HIV. Once those tests are positive, and they've determined that the patient has HIV, then they'll go ahead and start doing some viral load testing and more specific testing of HIV to determine how much of the virus has invaded the body, and that would be the quantitative RNA assays. So this is a drug therapy. These are the classifications of drug therapy used to treat HIV. As I mentioned, that slide in the beginning shows you where each one of them sort of works in the invasion of the HIV virus into the cell. The important thing to know and to educate your patient about is all of these medications are used to treat the virus and to inhibit the viral replication. It does not kill the virus. It's just very important for them to understand that. It will not get rid of the virus. It is inhibiting the virus from replicating, but they will still have it in their body. Once it's in there, they still have it. These drugs are just meant to control and to inhibit the replication of it. As I said before, they will be put on multiple forms of the drug. So they might be on a protease inhibitor, the early inhibitors. They might be on a group of these or a cocktail of these. And the reason they do that is because they want to hit that virus in multiple places so that it cannot replicate. The other thing is using monotherapy or just one of these drugs increases the ability of the virus to build up a resistance. It's a pretty tricky virus, so it could actually kind of find a way around one of these drugs if we only used one type of a drug to inhibit it. So we need to inhibit it in multiple areas. This is called highly activated antiretroviral therapy, or HAART, showing good results. Patients are actually doing well with all of these meds that we've developed over the years. An important teaching point to all patients is, yes, you do have to take all of these, and you do have to take them for the rest of your life until we find another way. You have to take these every day. You have to take them as ordered. You have to take them for the rest of your life. You can't skip doses because you don't feel well. You should always take these. If you feel like you're having trouble with one of them, because they do have multiple side effects, if you feel like you're having trouble with them, then you need to contact your physician, and we need to find a different type of the drug that may not cause the side effects. But you cannot stop taking them. If they skip doses, or if they take lower, they don't take as many as they're supposed to, that can also help the drug promote a resistance to the drugs as well. So they need to take them as, the bottom line is they need to take them as directed. And if there's a reason they feel like they can't do it, they need to contact their provider, and they need to stay in constant contact with their provider during their therapy so that they can be monitored for how well these medications are working for them. Your book has a great chart beginning on page 372 of all the meds used currently for HIV infection. A couple of them that I'll just point out, actually one of the ones that the entry inhibitors, enfuvirtide, sorry I can't say this very well, enfuvirtide, we'll try that, is one of the early entry inhibitors that is actually a subcutaneous injection. So extra education would go along with that. They can't mix it with other medication, and they need to learn how to give themselves a subcutaneous injection. So there's different things like that, but that one is a subcutaneous injection. So lots of education would go along with that one. So it's just more patient education. If they are somebody who does have the HIV virus, they need to make sure that they are protecting their partners from getting the virus. They need to be educated very well on how to do this. Lots of products out there that you can give them information on how to make sure that they are not spreading this and giving this to someone else. Teaching after a patient has been diagnosed with HIV. There's a lot involved in that. The biggest one for sure is potential for infection. So since they have the virus, they don't have the immune system that a normal person does, so they need to understand that they need to protect themselves at all time from ill patients, from kids that are ill, going to places, large crowds, things like that. A lot of it is also the problems that are caused by the medications that they're given. And really a big piece of education is that they need to continue to follow up with their provider always to kind of monitor their progress and how they're doing. A big part of a patient that's diagnosed with HIV is we want them to continue to be productive citizens and continue to be a part of society and feel like they're part of society. I feel like the social stigma that was once put on a patient with HIV has definitely improved. They're not as isolated. I feel like since we do have a better understanding of what this virus is, I feel like there isn't as much social anxiety, but there could be definitely some involved in that. And just basically talking with the patient on how they feel about that and getting them resources in the community so they have someone to talk to and they feel like they're not alone is a really important part of helping a patient with HIV. Thank you for your participation. The following slides are a case study just to kind of enhance your learning and to assess your learning. Thanks.